Hello everyone, this is Dr. Cui. So from this video, I would like to talk about how to treat the patient with different diseases, and hope it's helpful for you to start your residency training during the rotation. And all of this disease, the treatment for those diseases are based on my on the textbook, and we learned from the USME exams, and also based on my own clinical experience, and also from the other textbook I checked. And also, I would like to discuss each treatment plan based on each case. So hopefully we can cover all of those disease and all of those common diseases we will see during the clinical rotation. And also first thing first, so I believe the most challenging department we're going to rotate is definitely in the emergency department. So I would like to talk about those diseases the common diseases we are going to see in the emergency department first, and hope it will be helpful. Now let's get started. Okay, now we can see this. We have a 70 years old gentleman with acute chest pain for 20 minutes, and we see this blood pressure, heart rate, and the respiratory rate increased. And based on our experience, that if the patient have a acute chest pain, the blood pressure, heart rate, and respiratory rate will definitely be increased. So of course, those vital signs might be caused by the pain, and then also we see that the patient has a chest pain, and acute chest pain for 20 minutes. So the first thing we think about is definitely the acute is coronary artery problems, and we may think about myocardial infarction, or we can think about the patient has a angina, or the patient has we also need to think about if the patient has a pulmonary embolism, or the pneumonia, or the patient has some trauma, or anything like any problem in the chest, or in the heart, or in the lung. So based on this differentiation, so we may place the order. And since we are in the patient is in the emergency situation, we definitely want to treat the patient symptoms first. And in case the patient has some life-threatening conditions, we consider give the patient cardiac monitor and the blood pressure monitor first, and then give the patient create the IV access for the patient in case the patient needs some fluid. And also we give the patient EKG first to see if the patient has some heart problems, and the next we can we can think about to do the physical examination for the patient, just to focus on the heart and the chest, and to see if the patient has some if to see if we can find out some special manifestations during the physical examination, and then we can consider place order for the regular test like CBC, CMP, those blood tests, and troponin, and D-dimers, and CXR, and cardiac ultrasound. So uh, so let's go to the next step. So as I mentioned, and we did the physical examination for the patient, and we didn't see any apparent abnormalities, and also the patient, we placed order for all of these tests as we discussed, and the first and for the pulse oximetry, we didn't see any problems. For example, if the patient PO2 is about 90, 92, 93, so which is in the normal range, and then the next test we can get immediately is the EKG. So let's have a look at it. What's abnormalities here? Now, what we can see in this EKG, definitely the patient has a sinus tachycardia, and then we can see that in the lead 1, 2 AVF, V4 to V6 have the ST elevation, ST depression, and the V2, V4 has minor ST depression, and definitely the patient might have the cardiac ischemia. And here I want to let you pay attention to is to the AVR ST segment. You can see that in the AVR, the ST segment has elevated, and it's more than like 2 to 3 millimeter elevation, and it's higher than the V1 ST element. So here, just want to let you know that the AVR ST elevation combined with widespread V4 to V6 ST depression is a classic manifestation of left main coronary artery stenosis. And in order to further confirm it, another criteria here is AVR ST elevation is higher than the ST elevation in lead V1. Even the ST segment in the lead V1 has no elevation. So just want to let you know that. So, but still, I mean, even if we can see the positive signs in the EKG, we can still it still cannot guarantee that the patient will have the cardiac ischemia. But this will give us a clue that at least we need to suspect or highly suspect the patient has a cardiac ischemia problem. So next, we definitely need to give the patient some treatment and prepare for the patient to send him to the cath lab, to the PCI procedure or to the cabbage. So let's go to the next step for the management. And now the patient's in charge. So we are going to give the patient the morphine first to control the pain. And based on the pocket medicine, it's recommended to use 2 to 5 milligram IV Q5 to 30 minutes. But here, just want to let you know that it's better to give the patient 2 milligram IV first if the patient hadn't used the morphine or opioids before, because as we know that for the painkillers, especially for the opioid, always try to use the minimum effective dose first. So next is oxygen. You can either use 6 to 8 liter per minute by face mask or 4 liter per minute nasal cannula. And also aspirin. Here, just so here I normally use 4 pills, 324 milligram for my patients. Let them chew the aspirin, and just give them maximum dose to prepare them to send them to the PCI. And Plavix also loading dose 600 milligram first. And if the PCI is not available, may consider using 300 milligram for the lysis preparation. And nitroglycerin 0.3 to 0.4 milligram sublingual Q5 minutes 3 times. If it cannot control, if the patient cannot be controlled, may consider about using 5 milligram per minute IV. Next, we definitely need to use the metoprolol 25 to 50 milligram Q6 hours, and to maintain the heart rate to 50 to 60 beats per minute. And if the patient cannot tolerate metoprolol because of any reasons like dizziness or headache, so we may consider using some calcium channel blockers like verapamil. Start with 40 milligram TID, and then gradually increase the dose, and based under the maximum dose is 480 milligram per day. And then we may consider using ACEI or ARB to decrease the mortality for the patient to have a myocardial infarction. And here we can use the inoperable 2.5 milligram PUQD within 48 hours post myocardial infarction, and then quickly titrate dose, increase the dose. And if the patient cannot tolerate the inoperable, especially for the Asian people who has a lot of brain, who will have a cough after using the ACEI, may consider using the ARB. Another symptoms the patient normally have after ACEI is angioedema. So if the patient also has this problem, we can also consider using ARB, like losartan 50 milligram QD initially, and then 100 milligram for the maximum. And the losartan can also help the patient who has a high uric acid to decrease the uric acid level, because losartan can help the uric acid excreted from our body. And also we may think about using intensive statin treatment for the patient, like atorvastatin 18 milligram PUQD, and also enoxaparin is necessary, 1 milligram per kilogram sub-Q BID. And if the patient has some kidney problems, like the creatinine clearance lower than 30, may consider using the enoxaparin QD instead of a BID. And the next, we can send the patient to the cath lab. It's always optimal to send them within 90 minutes of first medical contact. And then we can have, when our job is done, and it's a cardiologist job to take care of the patient. But here, just want to let you know that normally after angiography in the cath lab, so if the patient has 1 or 2 vascular lesions, we may consider using give the patient a PCI for the treatment to implant the stent for the stenosis. Well, if the patient has 3 vessel lesion or the lesion is in the left main branch, like this patient may consider about give the patient send the patient to the coronary artery bypass graft. However, it all depends on the patient conditions and the interventional cardiologist experience and the skills. So I know some experienced interventional cardiologists can even do the PCI for the patient have 3 vessel lesions or even have the left main branch stenosis. So it really depends on each conditions. So now what happens if the PCI is not available? For example, if the hospital just had a fire accident or earthquake that the cath lab is not available. So what we will do for those patients? So definitely we need to think about the fibrinolysis. So for fibrinolysis, it's better for the patient with AMI within 12 hours of on-site, and if the cath is not available, so better within 30 minutes of a hospital presentation. And for the medication, we can choose is Activase or Altiplase or TPA. So once you decide to give the patient fibrinolysis, you need to make sure that if the patient has some contradictions. So there are absolute contradictions and relative contradictions. So for the absolute contradictions, if the patient has some problem in their head or in the brain, like the prior intracranial hemorrhage or neoplasma or some stroke, or so all of those problems in their head can cause bleedings. active bleedings, those are definitely absolute contradictions. And also, if the patient has some active internal bleedings or suspected aorta dissections or severe uncontrolled hypertensions, those are also absolute contradictions. If the patient is using some medications which can cause a patient to have a higher risk of bleeding, like a streptokinase, which is also a contradiction. So if the patient has relative contradictions, and if you are not sure if the patient has a risk for the bleeding, it's always better for you to talk to your attendings or supervisors to make a decision, to let them to make a decision, and let them to give the patient a full evaluation before the treatment. And also remember that once you decide to give the patient for treatment for the if you decide to give the patient the fibrinolysis, the patient will have a high risk of bleeding. So you need to keep an eye on this patient and also monitor those patients from time to time. And the medication, as I mentioned, we can consider using is activates. And here are two ways to treat to use this medicine to treat the patient. One is for accelerated TPA infusion. The other one is a 3-hour TPA infusion. Actually, there are no clinical trial to compare the two treatments and to see which one is better. So basically, you can just use either one, and based on patient weight, to give the patient different dose for the treatment. And if the patient has some contradictions for the TPA, so you probably would think about use heparin, like enoxaparin, to for the fibrinolysis. And here are two options based on different ages of the patient. So you choose you choose one of them to give the patient appropriate treatment. And after all of the treatment, then your patient is sent back to the ward. Now you can think about the second prevention. And the first thing you need to think about is to remove all of the risk factors, like the smoking, alcohol, or other risk factors. So if the patient has, just let the patient stop smoking, stop drinking alcohol, or all of those bad habits just need to be removed. And also give the patient antiplatelet treatment and control the blood cholesterol, blood pressure, diabetes, and just give the medication based on patient other conditions, and as well as other basic diseases. So now your patients get recovered, it's ready to be discharged, and then we can go to then we are ready to go to for our next patient. Okay.